Some of these issues are also DFS issues
okay.
that we should tackle.
Well, I was looking at it from the perspective of what we had enacted. We put in the budget to make, my understanding is to make some changes so that we could have some impact on reducing some of those out-of-network exorbitant costs and trying to rein those in. And I was just wondering if within that we'd made progress.
Yeah, I would say that I think that question is probably best directed to Department of Financial Services in the sense that they were the leads on negotiating that language, and they're the ones who are monitoring the implementation. But I think that the issue that you get to, which is the concern that when individuals, for whatever reason, end up out of network, whether it's they have an emergency, they're picked up in an ambulance, they end up at a hospital, it's not in network, and what kind of charges do they potentially face? I mean, that was the concern that I know a lot of people across the healthcare system had heard, was that bills were going to be sent to these individuals that were going to be exorbitant, and how could, or in their insurance companies, and how could we prevent that? And I think that's, DFS has really taken the lead on the enforcement of that act.
Thank you.
Thank you very much, Assemblyman. It's interesting because we've had several questions today regarding the Department of Financial Services and Health Republic and some of those other issues. I do want to point out as chair that they were invited to speak today to get everybody on the same page, and they're not here, unfortunately. Our next speaker is Senator John DeFrancisco.
Good afternoon. Doctor, don't you think it'd be a great idea, in view of the obesity problem in the state of New York and all states, to have a Governor's Council on Physical Fitness? What do you think?
I think we, as we've spoken about, I am a big fan of physical fitness and making sure that we move forward. I know there was some discussion about adding some resources for that at one point, and be happy to
Well, let me explain something. After our conversation, I worked with someone from your department. I said, I have no pride of authorship. Do something, put something together, and let me look at it. If it's reasonable, well, I'll change my bill. And so did Assemblyman Cusick. We did it. They did it. Guess what? It got vetoed again this year. So there's a disconnect someplace. And once again, I'm not trying to be facetious, but there used to be one when a subsequent governor by the name of Schwarzenegger was the poster child. For the federal one, I think it's time again to do it. And I'll volunteer to be the poster child if you would like. But I would really, truly need your help.
And I'm happy to work with you on this, and I do know it would need resources to move forward. And I recognize that there have been programs out there in other parts, and there was once when I was a child, the federal physical fitness.
Okay.
Program. Thank you.
Mr. Helgerson, now you got to pay attention to this, Marty, because Marty always says that I never think about Brooklyn, that back, I'm sure you don't remember this letter, but you certainly remember the topic, and you did receive a copy. November 12th, to a letter from Tammy Ramos, Practice Administrator, Hematology Oncology, Associates of Brooklyn. And they list a whole slew of other, including some from my area. And basically, and I'm going to read this because I'm not an expert in this area, that the Medicaid reimbursement policy for Medicaid, Medicare, duly eligible individuals was changed, and it was announced in July of 2015 that Medicaid will no longer reimburse partial Medicaid Part B coinsurance amounts when the Medicare payment exceeds the Medicaid fee or rate for that service. You're familiar with that?
Yes.
Was that implemented, first of all?
I know there were some concerns about the method of implementation, but I believe, yes, it has been implemented.
Okay, well, that was a bad idea. Because there's a lot of, and this is absolutely serious, some practices based upon this new rule have been estimated to lose approximately $800,000. These are medical practices. And you know what happens when they don't make money and they lose money? They don't take the patients anymore. And guess where they go? Hospitals, which is certainly not the best setting for someone going through chemotherapy. And secondly, it's much more expensive. So sometimes there's intended consequences, and later on there's going to be a speaker from the Community Oncology Alliance. And I'll send you a copy of his testimony because it'll be much more detailed than what I'm saying. But I would really, truly, and this is not being facetious, if you'd please take a look at it, because we're going to end up with more expenses and we're going to end up with a much more substantial problem. Fair enough? Okay, I appreciate that. And lastly, just so I understand this money that's being clawed back from New York City, does it have any, this is what I understand, that when the state capped the amount of Medicaid that the counties and the city would have to pay, that really we're picking up the balance, the new stuff, okay? And I heard that one of the difficulties was that there are some areas of the state less efficient than others. In other words, the increases they don't have to pay, so we're much more generous with how we're going to deal with those funds than if we had to pay part of it. Now, does this clawback have anything to do with that concept?
Not particularly. I mean, so when we implemented the, and I think it's an initiative that doesn't, that is part of Medicaid redesign, doesn't get enough attention, is that, and I remember full, when I arrived in January of 2011, county officials all across the state talked about how the growing burden of Medicaid was the #1 issue at the top of mind of every county executive and county legislators. And so in the face of that, and while the growth rate was capped, it was still rates of growth that were far in excess of what people thought they could afford. And at the same time, we were also obviously debating the property tax cap. And so when the property tax cap was imposed, we also moved forward with basically a phase down of the county contribution. So now where we are is it's a dollar amount that's now historically set in terms of it. And so it's not a growing share of any county's budget. What the proposal in the budget, this budget would do is basically ask that the City of New York contribute more, still capped, but more than they would have otherwise been asked to do. Understanding full well, and I think the rationale for that proposal, as I've stated, was that we felt that it was something that in essence is affordable for the City of New York. There's other benefits from the Affordable Care Act, for instance, that are going to local units of government, increased federal funding, other things that I think when you take and look at in totality at what has happened, there's substantial benefits still to the City of New York from all of the actions of the legislature and the governor of the past. But as we look forward to the program into the future, and we know we'll continue to have some growing costs under the global cap, that we felt that the city could afford to pay some additional contribution. But that said, end of the day, you know, it's a proposal that I know we would want to implement it in a way that would not negatively affect residents of the City of New York, and I think that's why we remain open to this conversation. If there's ways we can generate other efficiencies that aren't going to make the challenge something that can't be borne by the broad shoulders of the City of New York, then I think we're open to alternative ideas.
Thank you very much. I'll yield the rest of my time to the chairman in view of the fact that I know what they're going through.
Thank you, Senator Ironman.
Thank you. Assemblyman Abenanti. We set it up that way.
Thank you. Thank you, Mr. Chairman. I guess they don't want to hear from me, and I chased away the senators. I don't think we've discussed early intervention yet. I want to thank both of you for coming this morning, but I'd like to turn your attention to the early intervention changes that I'm seeing proposed in the initial budget. As I look through Article 7, I see page after page after page of changes. Why? What's the problem? What are we trying to solve here?
Well, one of the program has three changes. One is an administrative rate increase, so that's 1% to increase. One of the things we want to do is to get children screened quicker and have them pulled into the system before a full multidisciplinary evaluation is done. So that's something which will help get kids in quicker.
It's going to help with what?
Help get children into the system quicker, to get them screened quicker. Rather than
But you're adding a screening process before the evaluation.
Before a some may end up not needing the full multidisciplinary evaluation, so we're going to at least do a quick screening up front and do that.
But now you're going to be having parents go through 2 steps.
Well, they go through, some parents may go through the screening, and then the children will not need to go through.
What's the difference between a screener and an evaluator?
Will be multidisciplinary evaluation involving, let's say, OT, occupational therapy, physical therapy, and others as well.
Yeah, but if you have just one screener who's not trained in all those areas, then aren't you going to end up with the child getting maybe only one piece of the services and not the rest?
Well, the initial screening will be done to look at whether they need to have more of a multidisciplinary.
Do we have screeners who are trained in all these multiple disciplinary areas? Multiple in all the different areas?
Well, we'll have those who will know exactly what questions to ask and to be able to at least identify whether they need to go
Is
further.
this going to be a new profession, screener?
Excuse me?
Is this going to be a new profession? We're going to set up a whole new...
Well, we already, I would find out exactly who we would have doing those screening, but those are done probably by, or will be done by professionals. It doesn't necessarily mean it have to be somebody who has all OTPTs.
I'm sorry, the system here is terrible.
It doesn't need to be someone who has OTPT, speech and language all at one time, but the initial screening evaluation by questions.
I'm just very concerned because what I'm hearing anecdotally is that your requirements for providing early intervention within a short period of time are actually being skirted because the child is touched by the system, gets one of the many services the child needs, and now is off the list of the people who need services.
Right, but some of those children may not. Some of those children who are coming, what has happened is that the amount of time to get that whole multidisciplinary evaluation, if it's longer, then some of the children, we would want to identify them quicker, and if it's taking a longer period of time.
This is certainly something I'm going to want to hear from our experts in this field, because I'm very concerned that this is just a way to delay the services that are going to kids rather than speed them up.
Right. Well, 95% of the children will get a thorough evaluation as they need it within 45 days period of time.
Okay. The next thing you've added in here is they have to be screened by a standardized instrument. Are you trying to tell psychologists and all of the other people that they've been doing it wrong, and now there's going to be you're going to impose on them a new way of evaluating children?
Well, we have a screening tool that we will use, and I will get back to you about exactly what the details of that tool are.
Because I'm hearing that standardized instruments are a problem in many cases. I mean, we have Blythedale Hospital, for example,
Sure.
And the insurance companies are trying to apply a standardized instrument, so to speak, and they've never heard of half the diseases that the kids have who are in the hospital, and therefore insurance gets denied. I'm hoping it's not going to be the same type of thing here.
The other thing is we do need more occupational therapists, physical therapists, speech and language, and so we need to bring more into the system, obviously. And so we would definitely want to at least have these children at least initially screened to make sure we don't, those kids don't fall through the cracks.
Well, I'm understanding that a lot of people are dropping out of this field because of the mess that we have with the payment. So why don't we move to that? You're talking here about adding a 1% administrative fee. Is that on top of the existing rate, or is it part of the existing rate so that they'll get paid less for their services and more for the administration?
So it'll be an increase. It'll be increase.
It'll be a 1% increase.
I thought it was
and you've
1%.
allocated $400,000?
I'll check on that.
I think it's $400,000. How many providers are in the state of New York? Early intervention.
I have to check on the exact number.
Because it sounds to me like $400,000 it may be, a few dollars per provider. It's not very much.
Well, these are administrative fees, so if there's a group of multiple providers, then it would go to that team, right?
Well, I got to tell you, it's still not working. In Westchester County, we've lost a huge number of providers. Their names are still on your list because they're still owed money from way back when, and they're not going to say they're not taking new cases.
Right.
And some of the big companies, some of the really big companies that used to do this, have dropped out of early intervention, all because of the, quote, reform to save the people of the state of New York money. And so kids are not getting services that they should be getting. And I got to tell you, I've said this before to both of you, and I'm still very disappointed because I don't think it's been resolved. How much money is still backlogged and has not yet been distributed out to the providers from when we started this program? Do we have those numbers?
I'll get you the numbers. I don't have them.
Okay.
I mean, the claims usually come in with, most of the providers have gotten paid within about 2 weeks or so.
That's current.
Currently, yeah.
That's current.
Yeah.
Now, you're talking, one of the changes that's proposed in this budget is to require insurance companies to make payments, which I guess somebody's finally discovered that they're not now required to do, and really you should have discovered that before we went to the new system where you were taking all these savings on the basis of increased insurance payments, when in fact there's never been a requirement that they make these payments in the first place. And we have been pushing for that for years. We've tried to get those changes, never could get them. I see you're doing some of those now. But has the fiscal agent been able to improve the collections from insurance companies?
I guess it's also a DFS question.
So there hasn't been an improvement.
Do you know? Well, we'll check on that.
Well, okay. Well, I'm just disappointed because you're making all of these changes, but we don't have any financial backup to show that these changes are necessary. Because there are some of us who believe that there's a problem with requiring insurance companies to pay too much. Is there anything in the law today that limits insurance companies from putting caps on kids? Some parents don't want early intervention included in their insurance because they have sick kids who are going to need every penny of insurance coverage that they can get in the future, and this may be depleting their present insurance. So,
In terms of lifetime caps on insurance?
yes.
I mean, the Affordable Care Act, in essence, banned lifetime caps on insurance.
But does that
nationwide.
apply across the board or just to the cover? Is everything covered by the Affordable Care Act? Aren't there certain policies that are outside of that?
I think that's a question for DFS, but we can follow up.
I hope that you would be. Now, one of the other things, we're talking about Medicaid, you're talking that we have the lowest per recipient spending in 13 years. Have you done any measurement of the quality of the service that's being provided in exchange for the cutting of the costs?
Absolutely. So we monitor the performance in the program very rigorously. We have, in fact, been tracking performance, particularly in our Medicaid managed care products, which is now where the vast majority of our business all lies.
Do we have anything that shows?
20 years.
Do you have some kind of a report or something that we can look at?
We have a report card that we can provide you that, as I say, we can go back almost 20 years to show how performance has trended.
I'm still hearing from parents and others, anecdotally again, that they have a great difficulty in finding doctors, especially for kids with special needs, who can deal with their specialty.
Sure. I mean, I can't sit here and say that there aren't issues in certain parts of the state relative to certain subspecialties. I mean, we have challenges, for instance, in child psychiatry that are not unique to Medicaid, that are just, there are not enough child psychiatrists in the state or nationally to meet the demand. So there definitely are some areas of access problems, but overall, if you look at the overall statistics, I think you would see as clearly quality has improved even during a period of the program becoming
And one last question. There's a huge number of kids moving up through the system who have special needs. And we're finding that there are very few doctors who deal with adults who know anything at all about dealing with people with special needs. Is there anything that your department is doing to get more doctors into the area who are equipped to deal with people with special needs as adults?
Right, so this is an outreach that we have made and continue to make with all the physicians. I mean, this is a special, sort of a specialty that is growing, as you've mentioned, and we continue to reach out to the community on this, and also I think a lot of this also ties to graduate medical education to get those to be more interested and to get engaged in this. It requires an understanding of what the needs are in the community, and also how they could be partnered with others for basically a team approach to this problem, because it's not just the doctors. I mean, as I was mentioning, we also need more of other healthcare providers, OT, PT, but it also does involve the physicians as well. So we are doing outreach.
Thank you. I just hope that your department looks at this and finds some way to encourage more doctors to get into this and sets up training courses and whatever is necessary to get them there.
I agree.
Thank you. Thank you.
Thank you. Thank you, Senator.
Thank you very much. Our next speaker is Senator Persaud. She's left? Okay, then we would go to Senator Ruth Hassel Thompson.
Thank you, Madam Chair. Good afternoon. I didn't have an opportunity to hear your presentation, but fortunately I've had the time to sit and read it. And there are a couple of areas that I would really like to ask you to expound on a little bit. You touch on the executive's proposal of $200 million to help to end the HIV and AIDS epidemic. But the question, one of the questions I need to pose is how much of that is going to be dedicated to the supportive housing units that have been developed, number one? What are the timeline for that development to occur? And supportive housing presumes that there will be trained staff, and it's almost like a follow-up to what is being said in terms of being trained for these supportive services. We don't have an abundance of people that have the capacity to do that. So how much money is going to be dedicated to that? And the last part of the question for this question is how closely are you working with the Department of Labor to do that retraining?
Right. So thank you for the question about the ending the AIDS epidemic and all that we're doing. The governor has put forth $200 million as a multi-year plan, in addition to the monies we have already allocated for HIV/AIDS, which is $2.5 billion. The part of this is that the issues of HIV/AIDS are more than just the issue of health, as the social determinants of health, and as you raised about housing. I think OTDA would be able to answer that. The monies that have been put forth for the state that we are using to tackle this issue have been quite helpful in our efforts to eliminate or to bend the curve on HIV. I would direct your questions regarding the housing training, the training that's needed for that issue to OTDA, and also.
I wouldn't.
You would?
I would not preclude the health department from that training at all. And I asked the question that way very specifically, because too often the protocols require the health department's intervention. And so if you preclude yourself from making the plan or being a part of that plan, it's going to lack some of the sensitivity that is necessary in order to deal with some of the population. Supportive housing is not just, then the supportive housing that you're doing is not just for people with HIV and AIDS, but it's also supportive housing for homeless and those with mental illness. And so it is the health department's responsibility not to say that's OTDA. That is, I think that's one of the issues that we continue to have, that there is a disconnect from agency to agency in terms of how we sit around the table and determine what the best policy and best practices are when we allow one agency to be responsible when it really should be a combination of agencies.
I hear you, and I'm a big believer in going across agencies on all these issues we have, and I'm glad to work with OTDA about that, and also with all the other agencies on this. I know the supportive housing issue was something which we dealt with Medicaid issues, and I don't know, Jason, did you want to comment about that?
Sure. So, Senator, what I would say is that as part of Medicaid redesign, dating back to the very beginning, we've made supportive housing a major component of our strategy. In fact, I remember when we were crisscrossing the state in 2011, facing the worst budget deficit in state history, and a need to implement cost containment, we heard over and over again from a variety of different people across the entire state about how housing is so clearly tied to better outcomes and ultimately lower costs for so many people on the Medicaid program. And so out of that came our supportive housing program, our MRT supportive housing program, where we're spending $100 million a year. That's new and bunny up until the governor's announcement. Really the most substantial increase in state funding for supportive housing to come from anywhere in quite a long time came from Medicaid. We're the only program in the country that operates a program of this type. And in fact, I get more calls about this from other states than I do about almost anything else we do. So we are fully committed to supportive housing, no question about it. And I think the question though becomes, when you come to workforce questions that you raise, and so we put more money into it, but how do we know we have the professionals necessary to meet the needs of the people in those settings? And anyone who goes in tours supportive housing sees the magic that happens in those sites and those locations where you have professionals working with those individuals, transforming lives as well as health. And I think that one of the exciting things coming out of DSRIP, out of delivery system reform, is each of those 25 performing provider systems was asked to commit to a specific dollar amount investment in workforce. And that's workforce across the entire spectrum. And when you add up those 25 commitments, that's $450 million of commitment going in over the next 5 years to workforce. And each of the performing provider systems is developing it, their plan, but I think you're going to see a lot of non-traditional professionals, people not just doctors and others, but you're going to start seeing community health workers, you're going to start seeing other types of individuals who really are essential to success in those settings. And I think there's a broader understanding and appreciation of the value that housing has, and I think we just have a collective challenge of how do we make sure that these investments are used as effectively as possible.
Thank you. I appreciate your answer. The other thing I just want to comment on, you addressed, fortunately, the issue of some of the blockbuster drugs and how you plan to cap those. And I'm specifically concerned about Hep C because everything that I read says that by 2020 we're going to have a cure, but it's not going to be affordable to everybody. And I've got a deep concern that you become very aggressive in terms of how we address that and other issues of accessibility because we know there's going to be availability. So I just wanted to add that piece. The other concern that I have is that we talk about the governor's initiative along the lines of breast cancer. And interestingly enough, I just had a whole series of tests. I've been being tested every 6 to 8 months for over the last 4 years because they've seen something. But in the last couple of tests that were done, all of these are diagnostic. They've denied, the insurance company has denied to pay for some of these tests. And when you are doing everything that you're supposed to do in terms of preventing or early detection, and again, these become unaffordable. And they're not just, if they're unaffordable for me, what does that mean for somebody else who certainly has a much more limited income than mine, even though mine is limited? And so I say that, very honestly, saying that we're trying to move in a direction where early detection becomes relevant and just secondarily to what we do. And yet, if these tests are not being paid for, how do we continue to encourage that kind of participation on the part of the patients?
Right, so I hear you on that, and I recognize that we all have been down this path where bills come to us and some of it's not covered. As we move forward with this initiative, we will look and make sure that we can work with insurance companies and to make sure that things are covered. At this point, many things are covered, but we have had conversations about what else, how to broaden this, and so I hear your concerns.
Thank you. And my time is going to run out. But I just want to put this question, too, on your radar. The numbers of treatment and prevention programs, I noticed that you gave reports from 2015. We still have no new cases of mother-to-child transmission on HIV and AIDS, but I'm continue to be disturbed at the young age at which new cases of HIV are beginning to occur in communities of color, and we have not yet begun to address that issue.